So the IC today for us is beyond the lens, that is navigating cataract surgery in patients who have posterior segment disorders. I request Dr. Sarvanan to please co-chair the session with me. Dr. Manoj, Dr. Sharath, Dr. Sharath Shivan. So I'll start introducing the topic as well as my IC together. My first topic is preoperative posterior segment evaluation and mitigating the postoperative visual surprises. I'm Dr. Harshali from Srinetra Eye Care. Why is evaluating retina before cataract surgery so important? There have been several advances in the IOL technology, and combined with today's marketing about the cataract surgery, the post-operative expectations from the patient has increased markedly. There has been good amount of interest in the post-operative refractive surprises, however, an insufficient focus on the visual surprises associated with macular diseases and other retinal pathologies coexisting with the cataract surgery. The common posterior segment surprises that we often see are the macular edema, age-related macular degeneration, either a macular scar, CNVM, or dry AMD. Vitreomacular interface disorders such as macular hole, ERM, or VMT, and diabetic retinopathy, proliferative and macular edema, retinal detachment, and optic atrophy. So, why is it so essential? It's important to identify any undiagnosed pathology because it can limit the overall outcome in the cataract surgery, and patients may be having unrealistically high expectations. There will be certain conditions such as diabetic macular edema which will worsen post cataract surgery and will require proactive measures. The consent has to go beyond basic if there are associated pathologies. If there's a common thing, like if you find if you find a retinal pathology before the cataract surgery, it becomes a patient's problem, but once you find it after the cataract surgery, it's a surgeon's fault. So what are the key elements of posterior segment evaluation? One is a careful fundus examination, including the indirect ophthalmoscopy and slit lamp biomicroscopy, utilizing the retinal imaging such as the fundus photography, optical coherence tomography, FFA in select cases, and ultrasound B scan in mature cataracts. History and slit lamp evaluation cannot overcome any of the all these ancillary investigations cannot replace the history and slit lamp evaluation. For example, in this case, a missed RAPD led to an extremely unsatisfied patient in the post-operative period. So the key is to look out for cataract grade that is not consistent with the patient's visual complaints. So fundus evaluation, you need to do a thorough peripheral evaluation, including the indirect ophthalmoscopy along with the slit lamp biomicroscopy. I give you this example with a dense nuclear cataract who complained of a shade in front of his eye. Now, just a slit lamp biomicroscopy would have revealed just a dense cataract and poorly defined macular reflex. However, an indirect ophthalmoscopy in this patient revealed a macula on detachment, which would have been completely missed if the IO was not done. Another case to illustrate, a dense cataract with a hazy view would have entirely missed a proliferative diabetic retinopathy if a careful posterior segment evaluation was not done. To do a OCT or no before a cataract surgery is very controversial. It's more commonly done in patients who are going in for premium lenses. However, to do it normally for every cataract patient is a little controversial. However, there'll be almost around 10% of the cases or 1/10 of the cases who undergo cataract surgery who will be having any missed macular conditions which have been detected only with the optical coherence tomography. So when you're doing a OCT, you have to carefully look at the outer photoreceptor layer, that is the external limiting membrane, the interdigitation zone, and the ellipsoid zone, which indicates the photoreceptor integrity. Macular hole, if missed prior to cataract surgery, may not meet patient's expectation. Also, there will be other considerations such as considering a combined or a stage surgery, which has to be discussed prior to cataract. This all will be discussed by Dr. Sharath in greater details. You may miss a mild macular edema if a slit lamp is not done. Other macular pathologies that may be seen on the OCT are the macular telangiectasia, epiretinal membrane. The role of fundus fluorescein angiography is not too common and can be done in cases of dense cataract with asteroid hyalosis if you are suspecting neovascularization. B scan can be done in dense cataract, and in cases such as anterior segment coloboma, you may find an underlying retinochoroidal coloboma along with the retinal detachment. Patients who have raised IOP, non-dilating pupil, and dense cataract, a B scan may demonstrate optic nerve head cupping. If there is a posterior complicated cataract with posterior synechiae and non-dilating pupil, you may use ultrasound to detect the choroidal thickening, and that would delay the timing of the cataract surgery. In diabetic patient with uncontrolled diabetes and a dense cataract, he might be harboring a tractional detachment. Sometimes in a mature cataract, you might find a subtle thickening in the macula, and that could indicate a deciform scar, which would again limit the postoperative visual outcome. So, to discuss one of the case, it's a 60-year-old who was extremely unhappy with the cataract surgery done in one eye elsewhere because he was advised intravitreal injection after the cataract surgery. So, he's come for the other eye. The B scan looks normal. The OCT with poor signal strength does show mild edema. So, we proceed with intravitreal injection and then the cataract surgery, explaining the limited visual prognosis to the patient. So, there are key decisions that have to be discussed with the patient, such as the appropriate timing for the cataract surgery, whether you're going to do a combined surgery or a stage surgery, and IOL selection. Thank you.